Hi, I'm Amy Reyes. This week from Rheumatology Network, we highlight key presentations that were made last week at the ULAR annual meeting. There were plenty of interesting studies presented at the meeting, including one that showed high rates of remission in rheumatoid arthritis patients who are treated with conventional therapy. In another, researchers reported that high disease activity in rheumatoid arthritis may be associated with venous thromboembolism. And EULAR issued a series of treatment recommendations. One outlines best practices during the COVID-19 pandemic, and a second highlights recommendations for the use of platelet-rich plasma injections for knee osteoarthritis. Please visit our site, rheumatologynetwork.com, for more information on those studies. And in today's interview, we focus on managing osteoporosis treatments during the pandemic. New guidelines have been issued by a steering committee of the American Society for Bone Mineral Research. Dr. Mike Lewiecki, an expert in osteoporosis and bone diseases, is with us today. He is director of the New Mexico Clinical Research and Osteoporosis Center and a University of New Mexico program called Bone Health TeleECHO. In this interview, he shares his best practices for treating osteoporosis patients during the pandemic. Welcome, Dr. Lewiecki.
My specialty area of interest is osteoporosis and bone diseases. So I am director of New Mexico Clinical Research and Osteoporosis Center, where we do clinical trials on osteoporosis. We treat many patients for osteoporosis and I do consultations on osteoporosis. And I'm on the clinical faculty at the University of New Mexico, where I'm director of a program called Bone Health TeleECHO. And we've been using Zoom every week for the last 5 years. And we link up with physicians around the country and in many other countries to present cases to one another. And in recent months, we spent a lot of that time talking about exactly what's in this ASBMR position paper. We talked about how to continue treatment of osteoporosis patients who need, ongoing injections for therapy.
Yeah, I understand cases can be complex across the board in terms of what a patient needs, what medications they're taking, and what the recommendations are. And you've read the recommendations, you're obviously quite familiar with them.
Yes.
And would you mind summarizing them for our audience?
Well, the recommendations from ASBMR that have been endorsed by other organizations are addressing continuation of osteoporosis therapy in the setting of COVID-19. And the particular challenge with this is continuation of injectable medications that must be given by a healthcare professional in a setting where patients may be uncomfortable or unwilling coming to an infusion center or a physician's office to get the treatment they need.
So some medications are oral medications, others are injectables, and some are administered by IV as well, and that probably presents even more complications.
Yeah, let me give you an overall clinical perspective.
Okay, all right.
Many patients are treated with oral medications for osteoporosis. There's no problem there. A physician just needs to refill the medication when it's needed. Sometimes we monitor treatment with blood tests and sometimes with bone density testing. But all of those can be postponed to a later date until patients feel comfortable getting those things done. So oral agents are not a problem. There are some injectable medicines that are self-administered by a patient at home. So we have, for example, abaloparatide and teriparatide, which are daily subcutaneous injections. So as long as the patient can get a refill on the medication when they need it, they can stay home. They don't have to leave the home. They can remain isolated and they can still continue treatment. So in most cases, that is not a problem. There's an injectable medication, zoledronic acid, that's given by an IV infusion. And for the treatment of osteoporosis, that's often given once a year. So it's possible that the dose may be due at a time when the patient doesn't want to leave the home. Again, that's not a problem because this medicine is a bisphosphonate, and bisphosphonates have a long duration of action. So if the next dose is delayed by a few months or even more than a few months, most of the time it's not a problem because that medication is retained in the skeleton and it continues to have its anti-resorptive effects long beyond 1 year in some patients. So not a problem with zoledronic acid. Now, we do have 2 injections that are given in a physician's office where timing is important, and that's denosumab and romosozumab. It's the biggest problem with denosumab. This medication needs to be given by a healthcare professional once every 6 months. And if the dose is delayed by more than 1 month, there's a distinct possibility that bone density may rapidly decline and fracture risk may rise. So we do not like to delay the dosing of denosumab by more than 1 month. Now, if a patient is due for a dose of denosumab and they feel uncomfortable coming to the office, there's a few options. And there's a lot of local variation in how to address these issues. There's, state by state differences in how restricted patients are in terms of movement. Different patients have different levels of comfort coming into the office. So let me tell you how this is being addressed with denosumab. And this is something that we talk about quite frequently on our weekly Bone Health TeleECHO sessions, where we've had a lot of conversations about managing patients on medications like this right from the beginning of the COVID-19 global pandemic. So there are some physicians' offices that have remained open, and some have continued to give injections in the office for patients who are willing to do it. And often that's done with extra precautions for patients. Some offices I know have told patients to wait in their car until an exam room is open. They will call the patient on the cell phone and ask them to come straight into the office and straight to the examination room without having to wait in the waiting room. And that way they can get their injection, they can leave quickly, and they don't have contact with any other patients. So for some patients, that's worked. Other patients are willing to drive to the office but don't want to come inside. For those patients, we've been able to do drive-through injections of denosumab. So we've had patients wait in the car. They call us on the cell phone when they've arrived, and we've had somebody go out to the car and give them their injection while they're sitting in their car. So they just hold their arm on the edge of the window, somebody gives them an injection, and they drive off. And everybody's wearing a mask in that situation, and that gives them their dosing on time. And a lot of patients feel more comfortable doing it that way. Now, there are some patients who don't even want to do that. They don't want to come into the office, and they don't want to drive to the parking lot to get a shot. For those patients, sometimes arrangements can be made for them to get their injection without leaving their living facility. In some situations, that's been given by staff members at retirement centers or assisted living facilities or nursing home facilities, and they've been able to keep on schedule by doing it that way. And there have been some situations where patients have been taking this medication long enough that they feel comfortable giving it to themselves. So exceptions have been made to the rule that it must be given by a healthcare professional. And in those cases, if we're able to get the drug delivered to the patient and the patient feels comfortable giving themselves the injection, then that's a possible way to do it. And finally, when none of the above works, when the patient doesn't want to come into the office, they don't want to drive to the parking lot, there's no staff person or home health care nurse who can give it, and they don't feel comfortable giving it to themselves, we have to think of an alternative for maintaining their bone density. And that is often switching to a bisphosphonate, such as a lindernate. So a prescription can be called in. Hopefully that could be delivered to the patient, and they can start taking a lindernate once weekly and continue that up until the time that they can resume their dosing on the denosumab. So that's a kind of a panoply of all the options that we have for denosumab. Now, the other drug that is important for timing is romosozumab. That's administered as 2 injections, usually 1 in each arm, once a month for 12 months. And ideally, we like to keep patients on time for that as well. Again, some patients can be fast-tracked coming into the office straight to an examination room and leave quickly. And if they feel comfortable doing that, that's a way to address it. Some of the patients on romosozumab have had injections in the parking lot. Giving romosozumab as a self-injection or as an injection administered by staff at the facility is perhaps a little bit more complicated than arranging it with denosumab. And there may be some patients whose treatment is interrupted with romosozumab. And again, an option for that is perhaps to switch to a bisphosphonate. If they're able to take a lindernate, that's an easy, inexpensive one that can be called in, and the patient can start taking that until the time that they can resume treatment with romosozumab. So that's it in a nutshell, I think.
Well, it sounds like all of you have been thinking about every scenario that could possibly arise in order to be prepared. So that's good to hear. And one of the things I hear is there's concern for continuation of the medications, right? These are not medications you want to stop suddenly, right?
Well, that's absolutely correct. And it's the biggest concern with denosumab. We know if treatment is interrupted by more than 1 month beyond the due date for medication, that there can be a loss of bone density and fracture risk can begin to rise. So it's really critical, with more than any of the other drugs, with denosumab, that something be done. If they can't be given their injection within that 1 month window, then it's vital that they be transitioned over to something else.
Now, are you finding patients are receptive to this?
You know what patients seem to like the most at our facility is the drive-through option. So it's become very popular. I'm afraid patients may insist on doing this even after the COVID-19 pandemic is over.
Drive-through medicine.
It's a little bit of an extra strain on the office staff. We do it now because we have to do it. Now, that's not possible in a lot of facilities. So, I mean, we have a parking lot right in front of the door. It's easy to walk out and give the patient a shot. But if you're in a setting at a large hospital setting, for example, the place where the patient is able to park may be far away from where the physician's office is or the infusion center. So it's logistically more complicated for some places. So how to manage this depends widely on the local situation, bureaucratic obstacles sometimes, and patient preferences.
Right. Yeah. Well, it's good to know that, like I said before, that you've covered all your bases. The patients, though, how concerned are they about COVID-19 infection? I know that this group is not especially at high risk, but is that a concern among them?
Well, yeah, most of the patients getting these drugs are elderly, and COVID-19 is a very big concern for them. So it's not every single person, but I think the vast majority are very careful to take all the recommended precautions. They're wearing masks and they're staying home as much as they possibly can.
Sure. Yeah, that makes sense. Yeah. Is there
And of
anything
course,
else? Mhm,
we're making use of electronic communications as well. So
mhm,
we're doing video visits, we're doing telephone visits. Um, Typically, when a patient comes in for an injection, we spend some time with the patient to go over any recent laboratory tests. We sometimes will go over the bone density test if that's been done. We talk about any of their concerns that they have. And if they're doing a drive-through injection, they basically get their injection and go off as quickly as they possibly can.
mhm,
So often we follow that up with an electronic visit, either by video or telephone.
mhm,
The other thing that we've been doing is dispensing for some patients with doing a bone density test or getting the usual lab before the dosing of denosumab, provided with the lab that it's been stable in the past and the patient has not been changing anything and there's been no major change in their medical condition.
mhm. Okay. And what's the most common question patients are asking during these telemedicine visits? Is there one question that comes up over and over again?
It's really much the same as an office visit.
Mhm.
We chit chat a little bit about how they're dealing with COVID.
Yeah.
That's usually how the conversation begins. Often they have little questions about calcium and vitamin D and exercise. And
Mhm.
um, sometimes there's extra challenges getting exercise because some patients are used to going to the gym or they have certain routines that can't be maintained because of COVID. So we talk about that and try to address those issues as well as we can.
Mhm. Mhm. Good, good. Anything else you'd like to leave us with today?
Well, I think we covered it pretty well. I think we all need to be resourceful and we need to adapt to our local situation and according to patient preferences. So different patients have different levels of comfort for addressing these issues. And I think what we're trying to do here is just work with the patients and do whatever gets the job done.
Mhm. Mhm. Well, thank you. Thank you very much. I appreciate your time.
Okay.
Yeah.
Thank you for having me.
So thank you. May I ask one more question?
Yeah.
How do you pronounce your last name?
Lewiecki.
Lewiecki. Okay, good guess. Okay, for on my part. Okay.
You got
All
it.
right. Thank you. Thank you. Have a good evening.
Okay. You too.
All
Bye
right.
bye.
Bye-bye.